Hello, everyone. My name is Helena Pachon. I would like to thank the webinar organizers, and in particular, Dr. Renuka, for inviting the Food Fortification Initiative to present on wheat flour fortification. I'm going to start and finish with the main messages I hope you get from this presentation. 90 countries mandate wheat flour fortification with a diversity of nutrients. Wheat flour fortification improves nutritional status and other health outcomes associated with 4 of these nutrients. Measuring the impact of food fortification programs presents many challenges which can be overcome. Currently, there are 90 countries with mandatory wheat flour fortification, those shown in green. These countries require that 1 or more of the nutrients listed at the bottom of the slide be added to the flour. Interestingly, there are only data on the effectiveness of 4 of these nutrients, as we'll see later on. In this presentation, I'm going to answer the question, does wheat flour fortification have a health impact? I'm going to present evidence from effectiveness studies, which are studies undertaken in real-life conditions when food fortification is implemented at large scale after mandatory legislation. I'm going to begin by sharing studies that were completed after a country implemented mandatory wheat flour fortification. These results are in a book chapter that I wrote, which was published last year. You can download a free copy of the chapter at the link found at the bottom of this slide. The studies that I reviewed included 1 or more biomarkers of folate status or functional outcomes of folate status. In the second column, we find biomarkers of folate status, such as the prevalence of folate deficiency. And in the third column, we find functional outcomes of folate status, such as the prevalence of anemia. For iron, zinc, and vitamin B12, the studies included fewer biomarkers and functional outcomes, as noted in this table. The last row has hemoglobin and anemia. These can be influenced by multiple nutrients. I reviewed many study types, those conducted in single countries that assessed outcomes before and after fortification, either in the same or different individuals, trend studies that assessed outcomes multiple times after fortification initiation, cross-sectional studies that assessed outcomes and fortification exposure at the same time, and cost-effectiveness studies. Additionally, I reviewed cross-sectional studies that assessed outcomes only in the post-fortification period, studies that modeled the impact of wheat flour fortification in single or multiple countries, and systematic reviews and meta-analyses of multiple studies from multiple countries. I'm going to start by showing the results from flour fortification with folic acid. In all of these slides, a green color means the outcome improved after fortification, such as an increase in serum folate or a decrease in folate deficiency prevalence. A yellow color means that the outcome got worse after fortification, such as a decrease in serum folate levels or an increase in folate deficiency prevalence. And a blue color means that the study reported neither an improvement nor a worsening of outcomes after fortification. In 40 studies that assessed folate status or deficiency, more than 85% of them found an improvement after fortification. 13% showed no difference after fortification, and 1 study from Uzbekistan showed a worsening after fortification. Specifically, the prevalence of folate deficiency was higher in households possessing flour that should be fortified. 60 studies reported neural tube defect outcomes. The results from 47 of them are shown in the bar that has the red arrow. Overall, 88% of these studies showed a reduction in neural tube defects after flour fortification with folic acid. 26 studies reported on cancer outcomes. 50% of the studies reported an improvement in the cancer outcome after fortification with folic acid. 31% showed no difference, and 19% reported a worsening of the cancer outcome. In trying to reconcile these conflicting results, we see 2 trends. One is that studies published in the 2000s tend to show a worsening of outcomes, while the opposite is observed in studies published in the 2010s. And 2, worse outcomes are observed in studies with sample sizes less than 2,000 individuals, while studies that observe no difference or a decreased cancer incidence after fortification have sample sizes greater than 2,000 and going into the millions. An example of a study that made no difference for many types of cancer was a meta-analysis of meta-analyses that had 27 million data points. 96% showed no relationship or a protective relationship between high folate intake and cancer, while 4% showed a harmful relationship between high folate intake and cancer. Here we have another 17 outcomes reported in 26 studies. The outcomes are listed across the horizontal axis, starting with folate deficiency anemia on the left and ending with non-syndromic cleft palate on the right. 90% of the studies showed an improvement or no difference after fortification with folic acid. Let me explain the studies that showed a worsening after fortification with folic acid. For one study, higher homocysteine levels were reported in the post-fortification period. This is the opposite of what is expected. When folate levels are adequate, homocysteine levels are usually low. The authors suggest that in adolescence, there is a trend towards an increase in homocysteine levels, which was not affected by fortification. The second study was a modeling exercise where the researchers assumed that fortification with folic acid would mask vitamin B12 deficiency. 30 studies reported hemoglobin or anemia prevalence. 47% of these showed an improvement, 17% showed a worsening, and 37% showed no difference after fortification with one or multiple nutrients. There are 4 potential reasons for these conflicting results. One is the presence of non-nutritional causes of anemia in the population, which cannot be addressed by fortification. 2 is that nutritional causes of anemia were not addressed by fortification because the wrong mix of nutrients were added to the flour. 3, levels of nutrients or compounds used in fortification did not follow international guidelines. And 4, that fortification compliance was low. 8 different outcomes of iron status were measured after flour fortification with iron. Overall, most showed an improvement. The exception was iron deficiency anemia, where some studies showed no effect, and one found an increase in the prevalence of iron deficiency anemia after fortification. There are few studies that reported on vitamin B12 outcomes. They all showed an improvement after flour fortification with vitamin B12. Similarly, there are few studies that reported on zinc outcomes, and they all showed an improvement after flour fortification with zinc. In summary, folic acid was the most studied nutrient in effectiveness studies, and the most studied outcomes were neural tube defects, cancer, folate status, folate deficiency, anemia, iron deficiency, iron status, hemoglobin, and iron deficiency anemia. For all of these outcomes except iron deficiency anemia, the majority of studies showed improvements after fortification. For some of the outcomes, specifically cancer, anemia, hemoglobin, and folate deficiency, there were studies that indicated health outcomes worsened after fortification. Excuse me. The discrepant results for cancer may be due to years since fortification initiated and sample size differences. The discrepancy in hemoglobin and anemia results may be due to non-nutritional anemia that cannot be addressed by fortification, nutritional causes not addressed by the right mix of nutrients added through fortification, fortification levels or compounds that do not follow international guidelines, or poor fortification compliance. The preponderance of the evidence suggests that wheat flour fortification improves many health outcomes. However, because fortification may also be associated with negative health outcomes such as cancer, health monitoring should continue to assess these outcomes in countries with fortification. I want to allay any concerns you may have about cancer with trend data from the United States, where wheat flour has been fortified for decades. Here we have 2 graphs with the rate of colorectal cancer per 100,000 population in the United States. As you can see in the horizontal axis, the year of cancer diagnosis ranges from 1975 to 2015. Around this period, voluntary fortification of breakfast cereals with folic acid began in 1973, and mandatory fortification of grains with folic acid became effective in 1998. The left-hand side has the data for males, and the right-hand side has the data for females. For both women and men, the dark blue line shows a reduction in the number diagnosed with colorectal cancer during this period. There is no evidence that fortification with folic acid increases the number of people being diagnosed with colorectal cancer in the United States. Researchers reviewed data on the annual mortality in the United States from colorectal cancer from 1950 to 2010, which is the timeline that appears along the horizontal axis. They note in the dashed vertical lines that voluntary fortification of breakfast cereals with folic acid began in 1973, and that mandatory flour fortification with folic acid became effective in 1998. The data are presented for men in red and women in blue. For both women and men, there was a decrease in annual deaths from colorectal cancer over the 60-year period. These data suggest that folic acid fortification does not increase deaths from colorectal cancer in the United States. Moving on to the second objective of this presentation, there are several challenges with measuring impact in food fortification programs through effectiveness studies like the ones I just reviewed. I will mention a few of these challenges and potential solutions to overcome them. As of September 2009, all wheat flour used for making bread in Australia had to be fortified with folic acid. Because large-scale fortification is often implemented under a national mandate, it rarely offers an opportunity to have a randomly selected control group that does not get fortification for a period of time. The lack of such a group makes it difficult to infer causality for fortification. Thus, we cannot answer with certainty, does fortification cause an improvement in a health outcome? For example, these are data from 2 national nutrition surveys conducted in Costa Rica in 1996 in red and in 2008 in green. Between 1996 and 2008, maize flour and milk were mandated to be fortified with iron, and the iron compound used to fortify wheat flour was changed to a more bioavailable fortificant. Therefore, researchers used the national surveys to evaluate if there were changes in iron-related biological markers in children 1 to 7 years of age. We can see in the graph that there was a reduction in the prevalence of iron deficiency, anemia, and iron deficiency anemia in children between 1996 and 2008. Is it plausible that fortification contributed to the impact observed? Here we have the program impact pathway followed by the researchers. They assess various factors in Costa Rica's food fortification program. First, they assessed whether there was a potential to benefit from fortification. They concluded there was because micronutrient deficiencies were present. As we saw in the previous slide, iron deficiency was 27% in children. Next, they assessed if fortification policy had been created and legislation passed. The answer was yes. Next, they assessed if bioavailable fortificants were mandated. The answer was yes, as I mentioned in the previous slide. Next, they assessed if foods were fortified at mandated levels. They obtained data from the government regulatory agency that confirmed that 246 wheat flour samples obtained in bakeries over a 1-year period all met or exceeded the iron content required by law. Next, they assessed if fortified foods were consumed in adequate amounts. They analyzed dietary data and estimated that fortified foods contributed 49% of children's dietary iron requirement. And as we saw in the previous slide, they assessed the public health impact and saw a reduction in micronutrient deficiencies. This combination leads us to believe that it is plausible that food fortification with iron in Costa Rica contributed to the health impacts observed. This type of complementary information can be gathered for any program to argue for fortification's contribution to health impacts. Wheat flour fortification was mandated in 1951 in Chile. The iron compound was changed to a more bioavailable type in 1965. However, the country did not assess anemia at national level for the first time until 1974. This presents a problem common to many countries that have been fortifying for a long time. They were not able to get a baseline survey before fortification started. For those countries that have not yet started mandatory fortification, the obvious solution to this challenge is to plan for an evaluation from the outset. This requires dialoguing with stakeholders, fundraising for, and executing a baseline survey prior to fortification initiation. Additionally, if a country is not able to get a baseline survey, there are other study designs that can be used to assess the contribution of fortification to impact. Here's an example from Oman, where a national micronutrient status and fortified food coverage survey was conducted in 2004. This was a one-time cross-sectional survey after fortification had been mandated. Ferritin and C-reactive protein were assessed in non-pregnant women of childbearing age. This information was used to calculate the percentage of women with iron deficiency. Families were asked how much wheat flour they consumed in the previous 2 months and the total number of individuals living or working in the household during this time. Also, wheat flour samples were taken from homes and analyzed for the presence of fortificant iron. This information was used to calculate the monthly per capita consumption of fortified wheat flour. The researchers then completed a dose-response analysis and found that the prevalence of iron deficiency was lowest in women whose households consumed the highest amount of fortified wheat flour, 26.8% compared with 38.8%. These results are in the direction we would expect if flour fortified with iron is being produced and consumed in the country. While the study design does not allow us to conclude that fortification caused a reduction in iron deficiency, the results suggest that fortification is contributing to improving the iron status of women in Oman. Another challenge is that impact evaluation surveys can be costly. In June 2004, wheat and maize flour fortification with iron and folic acid became mandatory in Brazil. Researchers based in the city of Recife were interested in determining if the fortification mandate had an impact on the number of babies born with neural tube defects. The country has a national information system on live births. The information in this system was used to determine if a child was born in Recife with a neural tube defect. The researchers then counted the number of babies born with neural tube defects before and after fortification became mandatory. This research project did not require primary data collection by the researchers. They were able to use existing data to assess if fortification had an impact. This and the studies from Costa Rica and Oman are a lesson for us. We can use existing data, such as national nutrition surveys and live births registries, to estimate the impact of food fortification. For the 2014 Demographic and Health Survey conducted in Cambodia, decision makers added a micronutrient module for the first time. This allowed for nationally representative information to be available for several biological markers of nutrient status: iron, vitamin A, vitamin D, calcium, folate, vitamin B12, and iodine. This is an example of adding fortification-relevant questions to existing data collection systems. The resources required to add biological sampling to existing surveys such as this one are substantially lower than paying for a survey to exclusively measure the impact of food fortification. In summary, measuring the impact of food fortification programs through effectiveness studies presents many challenges. Some of these challenges can be overcome by gathering complementary information, which allows assessing the plausibility that fortification contributed to health outcomes, planning for impact evaluation surveys while planning for fortification implementation overall, employing non-traditional impact evaluation study designs, and using existing data and data collection systems to reduce costs. In conclusion, 90 countries mandate wheat flour fortification with a diversity of nutrients. Wheat flour fortification improves nutritional status and other health outcomes associated with 4 of these nutrients. And measuring the impact of food fortification programs presents many challenges which can be overcome. I would be happy to receive any questions or comments you have through my email address listed here. Thank you.